Thank you very much, Dr. Bueno. And I'm here moderating in place of Dr. Stacy Bretthauer, who had to return home for an emergency, for a family emergency. And I also have to thank him and other contributors for some slides that I'm going to present today. So I was asked to discuss how to optimize bariatric treatment process, how to improve outcomes while at the same time reducing costs. And I'm going to try and do that. These are my disclosures, none of which have any influence on the content of this. So there are some guiding principles that we have to follow. Obviously, quality is paramount. Safety is always going to be our first concern. And however, enhancing quality and optimizing it should not detract from cost effectiveness. They're not necessarily exclusive goals. And it is upon us as clinicians, and it's true, administrators do look towards us for guidance, that we are the gatekeepers to cost of care. As you know, it's often said that the stroke of a pen is probably the most powerful and expensive weapon that we have. There is, however, a high variability in understanding the cost of care and how and variability in reimbursement and how it impacts practice. And we must be evidence-driven, data-driven, and responsible to reasonable cost-saving efforts. And so this is why we're all here. We're here because we want to raise awareness and get information on how to conduct this. So the balance is how to innovate, how to improve care, while at the same time not increasing cost and of effective care. The variability in any service line, whether it's within one hospital or within several hospitals in a hospital system, can be one of the more expensive, more rapid drivers of cost of care. And this is why, in keeping with the prior speakers, standardization is so essential. We as clinical leaders need to be present at the table and be able to drive this change, and we need to expect some level of scrutiny or overseeing of what it is that we do, and in fact that's probably why accreditation has been so successful. So one of the main problems that we have, and what brought this all to light, was David Flum's paper from back in 2005, where he reported an unacceptable high level of death, especially among elderly Medicare patients. And this is what drove a lot of the accreditation processes that were triggered into place. Eric DeMaria in 2010 reported the results, the first results from the first database that we established back in the Centers of Excellence initiative that we have called the BOLD. And this included nearly 60,000 patients, representing 800 surgeons in 450 facilities. And what's nice to see here is our complication rate dropped to 15%. That's all major and minor complications, and the mortality rate dropped from the 4% that was mentioned to 0.1%. And this wasn't only us surgeons reporting this. Medicare itself, CMS, reported, as you can see here, gastric bypass complications 0.4%, mortality 0.2% in the Medicare population. And this is very nicely comparable, as you can see, to the more common and popular operations that are considered standard and safe. And you can see from this nice table that was created by Ninh Nguyen, where he looked at UHC data and showed in-hospital mortality dropped from 4% in 2002 all the way down to 0.6% in 2009 in the space of 5 years. And there are many reasons for this improvement, as you can see from this long list here, but I will submit the most important one was accreditation. So let's talk about that. We did have the Center of Excellence initiative in the past, and for several reasons and several factors, it was modified into the MBS AQIP, which is really a joint project between the American College of Surgeons and our Metabolic and Bariatric Society. And there's now a second edition of the manual, which explains the 9 standards that have to be created, developed, and upheld. And you can see a list of them there. And these are the accredited centers across the nation. And it essentially includes 850 centers, of which 772 are accredited. The other are participating, meaning not full accreditation, but data entering. And we have over 1 million patients now in the database. And for those of you who are interested in conducting research on these data aggregates, we have a PUF that's been available since 2015. Overall, the main concept and the main drive for this project is improving quality. And it includes, and in order to do that, we have to measure what we're doing, apply quality initiatives, and then remeasure again. And it includes all elective primary and revisional procedures. As I said, we have over 1 million cases now in the database. It uses clinical data, not administrative data, which distinguishes it from the typical administrative databases that prior research studies relied on. And it has highly standardized and validated data definitions, which we established are so important in order to be able to measure and compare apples to apples. Data are collected by specific data collectors, designated data collectors who are not in direct contact with the patient, thereby minimizing bias as much as possible. And then this data is returned, its feedback back to the centers so that they can make appropriate adjustments and corrections in their centers to improve quality. So these are some of our current national outcomes. Mortality rate has dropped even further to 0.1%. The major morbidity rate is 2 to 3%. Average length of stay across the nation for all operations is about 2 days. And our readmission rate has dropped to less than 5%, which, as you know, is a major cost driver in this area. We've also found that unaccredited centers have a higher complication rates, they have higher mortality rates, and also, according to John Morton's study, they are more expensive, meaning unaccredited centers had higher total charges, as you can see from the last bullet on this slide. Now, we've arrived at one of the principles or one of the benefits of having this amount of data, this large database, is that we can conduct nationwide studies. And one of them was the DROP project, which was aimed at decreasing readmissions, because we found that there was a large variability across the nation in readmission rates. And this study was designed in 3 bundles, as you can see, according to the phase of the patient as they advanced through the program, preoperative, inpatient, and postoperative, and it relied on using the data registry that we had. And these are the centers that participated in this study across the nation. And the patients were grouped according to their readmission rates into quartiles, and we took out the outliers, the highest 25% and the lowest 75%, so we can learn best practices and apply them to the rest. And we determined that there were several areas that were particularly beneficial in enhancing and reducing readmission rates. And you mentioned the discharge phone call. We found that to be one of the most important factors in reducing readmission rates, particularly if it's done within 24 hours of discharge. And you can see some of the other factors that were included. And this shows you the result. Overall, we were able to reduce readmission rates by 10.2%. And in the sleeve population, it was significantly improved by 18% reduction. And this is a graphic representation of that data. And you can see the marked reduction in readmission rates according to the quartiles there. So this was definitely a success story, and in summary, this study this initial quality improvement project was a good example of how we can take this database and apply it to improving overall outcomes. Dr. Bueno mentioned the energy study. Dr. Nuria also mentioned it, sorry. And this is an ongoing study. It is spearheaded by Stacy Bretthauer and Tony Petrick. And you can see there's a list of mentors there who assist the centers in conducting this study. You're all familiar with the enhanced recovery and how it impacts patients in different disciplines. This is information from the colorectal experience, and you see how ERAS can reduce complications, length of stay, reduces variability, reduces cost, and so on, and improves value. The main concept of ERAS, so that we all understand the whole premise of it, is to reduce stress. And these are different methods that we do that. By reducing stress, we improve outcomes, and we reduce length of stay, and we reduce, hopefully, readmissions as well. And these are some slides that I received from Tom Hopkins. To him, I owe him this credit, because he actually was able to translate this into dollars. And this is the situation in the United States. As you can see here, the last column is the USA, and you can see that we lag behind developing nations in many areas. I don't know if you can read that, but in terms of access, efficiency, and outcomes, we are lagging. And in terms of cost of care, the United States is the top curve there, and you can see how big the gap is in cost in delivery of healthcare in terms of finances compared to other systems. Value, as you know, is a formula of quality divided by cost, and this is what we aim to improve by decreasing variability and decreasing perioperative stress. This pie chart shows you essentially where all these monies are being spent, whether it's in surgery services, takes up 27% of our costs, intermediate room and board, what they call hotel stay is 25%, medical surgical supplies 18%. These are, and pharmacy, these are all areas that can be adjusted and realize true cost savings. So typically all ERAS programs categorize the patients according to the phase they're in, just like we did with the drop, preoperative, intraoperative, and postoperative, and then they're subdivided into which particular components of this area can be improved upon, and you can see all the different categories there, and they are all addressed. And at the end of this, and again, this is the colorectal experience, they were able to show that there was an overall reduction in length of stay and cost for all patients, of course, open, and slightly less in laparoscopic patients. And in terms of dollar amounts, this table shows you how the post-ERAS, there were significant savings in the total hospitalization costs and laboratory costs and imaging costs when ERAS protocols were applied to all patients. This shows you the improvement in value through length of stay. You can see these patients who had ERAS had decreased length of stay. And this is what we're doing for our bariatric population now. We're decreasing variability. We're maintaining homeostasis, decreasing risk, stress, and identifying centers that are outliers so that we can apply best practices to those. And this was launched in November 2016 and across 37 centers and is still ongoing. And this is how we identify those centers, again, using MBSA-equipped data, again, demonstrating the value of this database. And these are the current centers. So one last thing I wanted to say is, again, the crux of ERAS is multimodal pain management because we find that this is an important area that can drive length of stay, that can reduce readmissions, and also the concept here is to minimize as much as possible the administration of opioids by all these different methods that can be used either separately or in conjunction. We also win favors because there is an ongoing opioid epidemic, and the more we can do to reduce the impact of this epidemic, the better, especially with our patients who might be labile or exposed to opioid dependency problems. We can see here that there's increased length of stay and readmission rate and cost when patients receive significant amounts of opioids. One last thing I wanted to mention is that we do have a care pathway that is published for sleeve gastrectomies. Again, standardization is very important, and I would urge you to read this publication. It's in our journal SWORD, and we are in the process, as Dr. Lim mentioned, of publishing or rather creating a pathway, a standard pathway for gastric bypass, although you can imagine that is a little more complex because of the different permutations of that operation. So in summary, quality outcomes have undergone dramatic improvement, mostly due to accreditation and standardization. Current healthcare costs cannot be sustained. They have to be, the curve has to be deflected. Quality improvement initiatives are proven methods of adding value, and the concept of continued oversight, measurement, and application of quality projects is the key to continuing to drive sustained improvements in delivery of healthcare to our deserving patients. Thank you very much.